All right, so we got 30 abstracts in 90 minutes, 3 minutes each.
3 minutes each. All
You're
right.
on.
31, abstract 31 in Editor's Choice, Part 2. This one's about alternating the Motrin with the Tylenol or the ibuprofen with the acetaminophen. You know, so the parents, unfortunately, have bought into this whole direct-to-consumer advertising for the Motrin, longer, stronger, faster, you know, and they're selling it. And so now, unfortunately, the children's Motrin has wormed its way into the fever phobia and fever control approach. And a lot of people have said, well, if you give the Tylenol and it doesn't work, then you can give your child, you know, the Motrin. And they looked at 15 per kilo of acetaminophen, probably on the border of homeopathic dose, and then a typical dose of ibuprofen here. Now, alternating them is a little problematic if you want to do it strictly, right? Because the ibuprofen's Q6, the Motrin's Q4. So never mind that math doesn't really work out. But if you want to do it, this paper looks at what's going on with this and said that at a recent PEDS conference, they were at 50% of the pediatricians say they do it. That's not particularly compelling logic to me, but there you go. The parents in this study clearly believed that the combo was needed. In other words, they felt their kid was still too hot after getting just the Tylenol, and they felt that they needed the Motrin, even though the actual temperature differences measured over 6 intervals up to 6 hours only showed that the kids were hotter in the combo group at 2 of the 6 measurements. Never mind that, the parents, you know, buying into the phobia and the need for the combo, felt that that it was a better thing. So these kinds of authors conclude that routine usage of the combination approach, alternating, is unnecessary, and that there's only slight changes in the temperatures, probably clinically insignificant. A second conclusion that I would reach from the paper, just looking at what pediatricians do, what the parents believe, is that if you want to be a purist and say, I just think adequate dose Tylenol is fine, which I think is true, that you'll have an uphill climb convincing parents and pediatricians that that's what the literature says. And we've previously looked at some 20 papers comparing Tylenol as an antipyretic to ibuprofen as an antipyretic, and it's not faster, stronger, longer. It's you know, they're pretty much equivalent, and particularly if you push Tylenol at levels greater than 15 per kilo, you'll get there. And remember that for kids, you're not really worried about toxicity, right? Kids barely even have the middle metabolic pathway that makes the toxic endpoints of Tylenol. And so 20 is clearly safe. A lot of people go 25 as a single-time dosing in the emergency room. So this is sort of a straw man comparison in that we use the full dose of Motrin in the combo and then a sort of a straw man dose of Tylenol to compare it to. And so I think what this talks about really is 1, fever phobia, 2, parents have it, 3, pediatricians and nursing reinforce it. And if you want to be a purist and tell them that just Tylenol is okay for fever control, you're going to have an uphill climb.
I agree. It's kind of hard to get excited about this issue, you know, especially about lowering the temperature. I actually think it's more interesting when you talk about it as an analgesic. So let's take the other point of view. Why not do this? The two drugs work by different mechanisms. There's hardly any studies that look at taking Motrin and Tylenol together. They have completely different toxicities. You think that would be a perfectly rational, easy thing to do?
Except these kids had fever.
No, I already said that. We said that right. For fever, you know, who cares if they had the fever anyway that much? Now, to be honest with you, one thing I think you said just a little bit wrong. The difference, you know, at 4 and 5 hours here, it was 0.9 degrees centigrade. That's actually, 1.5 degrees Fahrenheit, and that's actually a whole lot. I'm amazed it was that much. We did a study years ago, almost a similar kind of thing, but we also showed that the Motrin actually did last a little bit longer. I don't think there's a question about it.
Yeah, so they say 15 minutes longer or thereabouts.
So I agree that this is what this study showed, but they didn't study alternating Tylenol and Motrin for the management of fever.
Right, they studied combo versus alone.
They did a single 6-hour trial. That isn't what the parents are thinking of doing. They're going to go home, and for the next 2 days, they're going to give their kids something every 4 or 3 or whatever. And so I don't know what that effect would be for something that's longer acting,
so
like ibuprofen. So I don't have any problem with people doing this. Actually, you know, most parents want to feel like they are helping their children. Better they're doing this than that they're giving them antihistamines or Sudafed or wanting antibiotics from you, that kind of stuff for this. So I don't think this is such a big deal. And I'm not sure they studied what they thought is the protocol for giving alternating
I agree with
ibuprofen.
that. My concern about the Motrin sort of invasion in the antibiotic, you see these kids who have these viral illnesses that last a week, 10 days. Now, there was the Children's Hospital Boston study that said for 3 days that there was complete safety, and it was a huge study, 80,000 kids. There was safety for using Motrin over 3 days. But the problem is once you get beyond 5-6 days, if they're using Motrin regularly, you get into a situation where you do start getting into the toxicity of Motrin. I had never seen kids with upper GI bleeding until Motrin took over. So you see these kids who've been sick for a week. The parents are giving them Motrin every 4 to 6 hours. And next thing you know, the kids barfing coffee grounds from their Motrin. Thanks a lot. I'm so glad you did that. And in that huge study, by the way, there were 8 GI bleeds on the Motrin side, none on the Tylenol side. But since this was such a huge study, they said that wasn't clinically significant. But that study really was handicapped in favor of the Motrin because it was only a 3-day study. We know that the GI bleeding really increases with duration of time the kid's on it.
So is there a product that combines Motrin and ibuprofen for Motrin and
Acetaminophen.
for pain?
Tylenol.
Are you? Can you buy something off the shelf
No.
that has that? Well, if you're a subscriber to Emergency Medical Abstracts, you'll know about a paper next month that has a combined ibuprofen and acetaminophen because it makes sense. Just like Michael said, why would you not do that when it's traditional to use multiple drugs that work in different mechanisms to take care of pain? The World Health Organization Pain Ladder talks about that kind of stuff. And why has this not been concocted before? But in any case, watch the abstracts.
Do you remember, was that from like Turkey or one of those places that...
No.
Well,
no,
was it a journal we routinely get, I guess is what I'd like to know.
No, I don't know where. I don't remember where it's from. It's about, a lot of these studies on analgesia are about dental pain. They start off there, pull teeth, and see how people feel. And this is a dental study.
All right, 32. So 32, prescribing trends, antimicrobial prescribing trends for upper respiratory infections and its effect on return visits. So there's some amazing statistics in here. This is the first part that's interesting about this is these are people from the University of Minnesota who studied Oregon. I always love that. Why don't they just study Minnesota? It was the same as when the folks from Massachusetts studied New York for bad outcomes. They just don't want to study their own. So anyway, they looked at giving antimicrobials for upper respiratory infections, and they said from 2001 to 2003, it stayed the same for otitis media, about 77%, pharyngitis, 50%, declined with a diagnosis of bronchitis from 70% to a whopping 61%, something you clearly don't need it for, and sinusitis from 77 to 74%. The common cold from 13 to 12%. To me, almost meaningless differences for things that we know are mostly always viral. So just astounding statistics at how often people get antibiotics for viral infections. Then what they said, the prescription of an antibiotic was associated with the increased likelihood of a return visit. Well, why would that be? Well, first of all, their symptoms don't get any better because it's a virus. And what have we taught them? We taught them that you need an antibiotic. So, I think this is sort of almost a foregone conclusion.
Well, the other reason they might come back is because you gave them enough amoxicillin, that 90 mg
Diarrhea,
per kg
right.
thing. So now the kid's got in the United States, it's pretty clear. We believe diarrhea is the clear cure for otitis media.
Right.
It'll take your mind off of it,
Not used topically, though, I hope.
Yeah.
All right, 33. There's a couple of these. Now, don't get nuts about these papers, guys. I know. I'm feeling
Yeah,
a little.
I got a couple,
I'm
yeah.
feeling the love.
chomping at the
I'm
bit
feeling
here.
the love. So this is about procalcitonin and determining whether a kid has a bacterial infection or not. This is Children's Hospital of Boston. 234 little kiddies, less than 90 days old, with fever without apparent focus. A definite or possible serious bacterial illness was felt to exist in 18%, which is 42 kids. So 42 out of the whole bunch. 29% of the kids who were less than 4 weeks old versus 15% of the older kids, so disproportionately high in the 1-monthers. Most of the serious bacterial illnesses were urinary tract infections. As a matter of fact, of the 42, it was 31 of them were thought to be urinary tract infections. The mean procalcitonin level in people who had serious bacterial illnesses was 2.5. And those who didn't, it was 0.4. 0.4. So big difference, 2.5 versus 0.4. As a discriminator, they said if you pick a number, we think that we could have pretty good sensitivity determining who has serious illness versus who does not. And it was certainly better than the white count or CRPs. And people still will get the white counts thinking that they may help in decision making in these cases. So this is this is one of a couple papers that talk about this stuff. Does anybody have the ability to order this if you wanted to?
Good.
You're Australia, right? There you go. They're always ahead of us. You know,
I'm not sure this is ahead.
All right. Well, we're going to talk about some of the other way where, in fact, maybe you don't give them the antibiotics if the procalcitonin is the other way.
Let's go back to what I always love is all these studies from Children's Hospital Boston. They will say in 1990 they'll do 10,000 lumbar punctures in kids with febrile seizures, and their conclusion is you don't need to do an LP with a simple febrile seizure unless they have clinical signs of meningitis. Then 10 years later, they'll publish 10,000 more LPs for the same condition. The only people who don't believe their studies are them.
And blood cultures, they do the same thing. Blood cultures,
over
LPs,
and
they won't
over
stop
again.
doing them.
Well, this one is a good one not to believe. I mean, and those of you that hear the tapes and all know that Jerry Hoffman got apoplectic at this one and the next one, which actually doesn't. It's not an indicator of anything.
That's one of the reasons to do it.
That's right. It's not an indicator of anything usually, except in this case. And I'll mention it more with the next one, which is by the same group. In fact, the same authors. They switched around the lead, author kind of thing. And not only the same group and the same authors. Are you ready for this? The same patients. And
the same journal.
1 month later. I mean, and I say this, that's called mileage.
And the same authors are being supported by the same manufacturer of the procalcitonin test in both studies.
And is that true? I don't know if that's true, but that makes sense.
True.
All right. So the obvious things that were wrong with the ones that we just kind of said there is just the fact that you have a median difference in a number. That in no way says that helps you in making any kind of decision. These tests are not sensitive or specific enough to use it in a way. I mean, you're trying to rule out what you think is a serious illness. On the other hand, what is really this SBI, this serious bacterial illness? None of them are serious. The disease doesn't exist hardly, really. I mean, they're talking about pretty much UTIs, which means that if you catheterize all these kids, which is what they did, that some of them will have bacteria in their urine. And since they happen to be febrile, you said that was it. That was a serious bacterial illness. A couple of the others had gastroenteritis. So you're using a horrible test to distinguish between conditions that don't even matter. As if that wasn't bad enough, the next article used by the same authors, the same patients, in order to see maybe it would be helpful in those kids that had a recent vaccination. They come in with a fever, and they're talking about, less than 90 days, so you're kind of worried about it. And maybe that would be great. If you had a test that you could do, and if it came back positive, it wasn't just a response to the vaccination, which some kids get, but it really meant a bacterial illness. Well, it sounds pretty good when you read the first sentence of this. The last one had what? 459 patients. This one, huge amounts of patients there. But the only problem is, let's see, what is the total number there?
271.
271. And remember, if you look at the other one, it was 230 some odd, right? So you think they had 230 and then another 270? No, The only difference here they now have 44 patients. So it's actually a study of 44 patients, okay? And of those 44 that had, so SBI was diagnosed in 16% overall, just almost like the last study, because it's the same patients, really. Two of these 44 had a history of recent vaccination. So the 44 patients that had the SBI, 2 of them had recent vaccination. So it's really a study of 2 patients. That's what they're looking at. So they want to see how the procalcitonin did on that, and here's how it did. The 2 patients who had something bad, which turned out to be a UTI, which actually wasn't bad, those 2 patients actually had a positive procalcitonin. So they go on to say, the balls of these people are amazing, that it was 100%, it's unbelievable, they say 100% sensitivity. And then they kind of say in the smallest print, by the way, the specificity, what do you think it was?
20.
No, 8%. That's what it was. So it got 2 out of 2 patients, who actually had it. It diagnosed every single one basically, except 92% of the patients of all the rest, they said it had it and they were wrong. And then they go on with those numbers to say that it appears to be useful to the exclusion of SBI in infants with fever after vaccination, because they had 2 patients in whom it was positive and, about 40 in whom it was negative. It is just the craziest study I have ever seen.
So 35 is the last in this series.
This is the craziest one you've ever seen?
This one, actually I misspoke. The first 2 were from Children's Hospital Boston. 35 is the one that's by the guy with the conflict of interest who is a speaker for the manufacturer of the Cryptor. So this is the one with the conflict of interest, is 35. And this is a Swiss author that says, this is all about diagnostic confidence. So if you saw a kid and knew that their procalcitonin was low, you wouldn't worry about them having a serious bacterial illness, so you wouldn't treat them with antibiotics, and that would all be great. So the uses of this is sort of like a flu test. Right? This is like those studies where they did the rapid flu test on the kids. If the clinician knew they had flu, they wouldn't work them up and wouldn't treat them with antibiotics unnecessarily. So that's their sell point. And so first you got to look at their numbers. So in the usual care group with a respiratory tract infection, this is in Switzerland, too many pharmaceutical companies there, I guess, 97% of the kids got antibiotics. Ooh. So we know the vast majority of those weren't indicated. They said maybe 15% of the kids had pneumonia. All right. So that means 85% of them were illnesses for which antibiotics probably weren't indicated. So that's the usual care group. So you're going to compare your now procalcitonin group to that group for which they all got antibiotics almost no matter what. In the procalcitonin group, only a quarter ended up getting treated with antibiotics, and they were, of course,
that's good.
So they said that this really worked. When they compared for other outcomes, there was no change in comfort, days off work. The main difference was that if you didn't treat them with antibiotics, like we saw in the earlier papers, what did you see? There was less adverse drug reactions because, of course, they weren't on an antibiotic, which caused diarrhea, candidal vaginitis, and other fungal overgrowth problems. So there was a full day less of adverse drug reaction. So they say that this bad test with a poor specificity would allow you to do the right thing, which you should have known how to do the right thing without the test, which is to sit tight on giving antibiotics. So I'm not that impressed. I think procalcitonin, although they're arguing that it performs better than white count and sed rate and CRP and those types of tests, it's very similar to them in that it's a very nonspecific marker. Why, of course it goes up in serious illnesses. The question is, what's the Venn diagram? So if this is the circle of people who don't have that illness, if the circle for the procalcitonin is way over there, then that's great. The problem is here's where the circle for the procalcitonin is. The circles are in different locations, but they overlap tremendously. So it's discriminatory value. Yes, the circles are in statistically different places, but if the overlap is big, its discriminatory value is crap.
So you don't like it? Is that what you're saying?
I'm not ready to buy on this one yet.
Well, the fact is it took antibiotics down from 100% down to 25%. And if that accomplished a really good thing. So why don't we just
make a bogus test that costs nothing and tell them it's negative?
Well, this is better. It's a bogus test that costs a lot.
Well, it's very analogous to doing flu tests. If you have a person that comes in with a flu-like illness and you do the flu test and it comes back positive, the person has the flu, and the studies have shown that people tend to give less antibiotics, do less CBCs, do less urinalysis when they do that because they have a level of confidence in the diagnosis. So these doctors, based on this, had a level of confidence that I don't need to give antibiotics for this because I was told that if there's a low level of procalcitonin, it's all most likely viral, and whether that's true or not, basically, it got the job done. We've done.
Barnum and Bailey said that there's a sucker born every day. Just because these docs now had confidence doesn't mean that the test works.
Let's ask the one guy that has it here. Do you actually, use it to make a decision?
We studied it as best as
Yeah, so it's a very non-specific.
Which is not a good test either. Not much, right? You can.
So,
how long have you been using it? Years.
Really?
So what I can't imagine here is its use in primary care. I mean, unless you have the machine that measures procalcitonin in your office, a lot of these folks can't even get an ankle x-ray in their office. They got to send them to the hospital for it. So you're going to now send them somewhere to get this test and get it back tomorrow, maybe, and then use it to
It says
diagnose them?
19 minutes.
They got it in 19 minutes. That's because they had the machine.
And it was in 53 primary care doctors' offices.
I know.
So is it your impression it's a pretty inexpensive test and no big deal?
Quick and cheap and not good. That's
right.
Well, actually, that's better than.
all right.
All right,
Sedway
moving on.
takes a long time.
Moving on. 36. Occurrence of serious bacterial infections in infants aged 60 days or younger with an ALTI. So this is from Pittsburgh. They took a bunch of kids, 182 afebrile, well-appearing kids, 60 days or younger, who had an apparent life-threatening event, and put them in a hospital. I think everybody does that. And they said they actually looked okay. They didn't have any reason that they could come up with for the episode. They didn't have wheezing, trauma, GERD, choking, or vomiting within 20 minutes. And then they got testing at the discretion of the physician. So a lot of these kids got microbiologic testing. Some got blood cultures. Most of them got a chest X-ray. Some of them got urinary, tested for urinary tract infection. And they said in 2.7% of those kids that were well-appearing, they found something. One was a positive test for pertussis. Okay? One was a UTI, and 3 were positive blood cultures. And so from this, they conclude, they don't tell us the age of these kids, but they say it was more common in the kids who had been premature. They say that it was associated with an increased risk. They suggest a strong consideration of serious bacterial infection in these kids. And I think sort of ALTI is like syncope. It's a symptom of something. It's not a disease. So what caused that? Even at this, did they really think that the urinary tract infection caused this kid to look like they almost died? I think they're picking up incidental infections.
Yeah, background noise.
So they have some incidental infections in these kids, and okay, sometimes you treat them. I don't know that they ever came up with that was a cause and effect kind of thing, but they say occasionally these kids are going to have something.
The pertussis probably called it, right, with the whoop and the
they have no apparent cough. Yeah. They have no cough.
Yeah.
So I don't know, if that was a false positive or what. But anyway, that's what they do.
37 is a
Before we leave the ALTI thing, right now in Los Angeles at Children's Hospital and at USC and a whole bunch of other places, not a whole bunch, but a few other places, they're trying to make this, like Neal and Mike said, most people probably admit these ALTIs. We don't want to take the chance of sending one of those home. You always get the history. You're not really sure. They're always telling you, I did CPR. How blue was the kid? How long did it last? 2.5 hours. You look at the response time. It was 4 minutes on the pre-hospital care. It's hard to sort them out. So we've kind of been no-brainers about it and brought most of these in. But now there's a whole bunch of work being done on trying to sort out what's a low-risk ALTI so that we can send a bunch of these home from the emergency department, which, I applaud their efforts, but I don't really necessarily want to be the first person to try out the low-risk ALTI criteria as an ER doc, where they come up with some, validated tool where they say it wasn't a preemie, the kid didn't turn anything beyond violet, they never made it to indigo on the colorimetric analysis, and the tone of their muscles was, enough so that when they picked up, they didn't look like a sack of potatoes. You can send that home. But that's the direction this literature is going, is to try and identify low-risk ALTI criteria so that we can send them home, because most of these admitted ALTIs don't have anything. So it's going to get harder, not easier.
Most of them all have GERD.
Yeah. And that's surprising, but that is the most commonly identified or attributed cause to these ALTIs, is they get a little regurgitation of acid onto their vocal cords and go spasming and turning blue and sputtering and those kinds of things.
So the reason I mentioned this is like syncope, it's the same difficulty with syncope. Something was happening an hour ago, and it's obviously not happening now. What was it? That's the trouble with it. You don't have a trail to figure out with it. So unless you have some concrete test, it's all presumptive when you find something here, and this is just as presumptive.
And actually our interventions for ALTI, this whole thing, the pat on the back stuff and all the stuff we send the mothers home, drives them crazy. Parents go crazy for months, about this. None of those have been shown to have any effect on anything. It's just treating ourselves, expensive, difficult things. But, this is the deal. We were talking about 95% confidence intervals earlier. I mean, if you had If you had 500 of them that you looked at and nothing happened, so he talked about you still might have 1 in 200 that would a bad thing would happen. Are you be willing to? You don't want to be the one that sent the 1 in 200 home. So we're going to have to be careful about this and have thousands of people and really look at it pretty carefully.
I don't think we should even bother. It's a waste of time. You know, what's one day in the hospital kind of thing? It's like it's not worth the effort. Nobody's going to do it. Nobody will have the testosterone to send these kids home saying, well, here's the criteria. Yeah, right.
It's
not
coming.
going to happen.
Trust me, you're going to start seeing it.
I hope
Ian Steele will do it. You know, he'll come up with some rules. They got the knee, they got the ankle, we got the ALTI rules. 37 is lumbar puncture. This is the study that Neal was referring to. So the
This
American,
is the second or third one they've done. This isn't the first one. Anyway, go ahead.
the American Academy of Pediatrics says strongly consider lumbar puncture in febrile kids seizures between 6 and 12 months of age, and considered in 12 to 18 months of age. So again, Children's Hospital Boston, 700 children with a first febrile seizure. They excluded those that looked clinically suspicious for bacterial meningitis or ill appearance, which was 0.5%, meaning that the vast majority of them were not excluded. Lumbar puncture was done in 70% of the kids between 6 and 12 months, and 25% of those between 12 and 18 months. And there was not one case of bacterial meningitis identified. 80% of the kids had been immunized, had immunizations, and 98% of them were considered to be up to date. So the AAP guidelines strongly consider. Well, this would suggest that the likelihood of you getting anything on a first febrile seizure in a kid who looks otherwise well is going to be very, very, very. It's not going to be.
Well, that's how small it is. It was 0 out of 704, right? So 0 out of 704 means the upper limit of the confidence interval, as you all know by now, is what? 4 in 1,000? Something like that? 0.4%. So we're just about, if you add their other two studies in, we're down to much less than 1 in 1,000. And the simple fact of the matter is, if it's a febrile convulsion and they wake up afterwards, which is what a simple febrile convulsion is, obviously it's not caused by meningitis. They wouldn't wake up. We've proved this so many times, and I do think most people, I'm sure in the room,
The conclusion here is don't bring your
So
kid to the Children's Hospital Boston because in 2010 they're going to publish another study on the next 1,000 kids they LP'd. It's like, when will
No, I
they
think
stop?
you can avoid the LP if you do a procalcitonin.
Yeah, maybe.
And you got to, as the next article shows, you got to catheterize that bladder. That is just so critical. I would hate to see the incidence of urethral tears they got up there in Boston. That Commonwealth up there, it must be bad because they're doing a lot of catheterizations on little boys. Number 38, in some way I like this because I think it's the first article I've seen on the crying infant. So not somebody comes in with fever or ALTI, but just comes in crying like that. You don't see that investigated very much. They point out that kids cry a lot, if you didn't know that, when they're young, an average of 3 hours per day, with a peak occurring during the evening hours, when you're trying to watch The Wire or something like that, because they just want to be annoying, these kind of kids. They went to the Rick's favorite hospital in Toronto, we've heard about before, the Hospital for Sick Children, for a complaint of crying. They worked them up the wazoo, and guess what? They got 52 specific diagnoses they did out of 238. That means 5% had what they called a serious bacterial illness, which, guess what, turns out to be a UTI almost every time. So they have the serious ones. They had a total of, there were only 2 of the 12 or something like that, only 2 infants, each aged 3 months or younger, was ultimately diagnosed with a UTI that did not have a clinical picture that would have been diagnosed in the emergency department. So after doing the whole thing, putting on their war paint, doing all that kind of stuff, they came basically out with 2 UTIs that they, might not have found sort of otherwise. And, it
So this paper is trying, there have been several of these, intractable crying papers. There have been several, 4 or 5 anyway. And the conclusions of the other ones were look for corneal abrasions, look for hair tourniquets, make sure you take the diaper off and check for hernias, fissures of the rectum, and the, rectal fissures are in there. That's sort of the standard litany of what you're supposed to look for when the kid won't stop crying. And sometimes you'll find some of those. This paper tries to say, and cath them.
Then they really won't stop crying.
Yeah, and I'm not,
I'll give you something to cry about.
Yeah, and I'm not sure the data here is strong enough to say I'm ready to add the cath. this whole kind of thing over the last 10 years of calling urinary tract infections serious bacterial illnesses, that have to be managed and treated. I mean, if this was true, at the rate they're saying it's true, and this is something that Jerry says all the time, then what happened to our generation? How come we aren't all on dialysis right now from our untreated pyelo?
Because we all got antibiotics for our otitis media.
Yeah, because we all got antibiotics for our otitis media. But in any event, this is one more paper to add to this list. And by the way, of the people who didn't have a urinary tract infection, they found the usual kind of stuff. 39 is one more of these papers. So this is a great paper. It's not the only one of its kind, but it's good data. They looked at 8,000 kids, 3 to 36 months, with a fever greater than 39 degrees in the years 2004 to 2007, where there was a high density of these kids who were vaccinated with the quadrivalent anti-strep vaccine and HIP. So basically the post-vaccination era. And so these kids came in, and even though they knew there was nothing, they worked them up. So they worked them up. They did cultures. And what they found was there were 21 and this was a retrospective analysis, so they waited till afterwards, saw how many of them bounced back, how many of them died, checked the morgue, they did all that. And what they said was there were 20, on the retrospective, when they knew the final outcome for the kid, there were 21 true positive blood cultures, of which strep was 14, and unfortunately, there were 159 false positive blood cultures. So one of the conclusions here is that chasing the blood in these kids will result in a 6-to-1 false positive to true positive ratio. 6-to-1. So you're really chasing your tail, sending blood cultures on these things. You're going to be, doing that, going crazy about that. And that the overall bacteremia rate, which we used to know in the pre-vaccine era was, if you wanted to say what was the positive blood culture rate that was true, we used to say it was somewhere between 2 and 3%. Now in this study, it's down to 0.25%. So you're supposed to, without doing the culture, in a vaccinated child, have the courage to say, we're pretty sure it's a virus. You don't need anything. 0.25%. And working them up is futile. But I work at our Peds ED. We have a Peds pod. And I get over there, and the first thing they do is they want to screw up my 7 a.m. shift. They hand me this list of people they sent cultures on yesterday and go, let's find out what happened to these people. I'm like, throat, no, I'm not calling. 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 Then it's like blood, no, I'm not calling. Blood, no, I'm not calling. When you sent them home, I'm not calling on these. I'm not following up. The data doesn't support it, but the pediatricians keep doing this stuff, and they want you to follow them. The only culture I'd be willing to call on tomorrow is the CSF. You thought the kid was sick enough to warrant you're poking a hole in their meninges to get some brain juice. All right, I'm going to call tomorrow. But all those other ones, I mean, what were you looking for in the throat?
I'm going to guess.
You're going to find.
I'm going to guess they're not going to make you dean of that medical school.
Yeah, no, eventually they'll stop doing it.
That probably will. And the thing you have to remember is the bacteremias, the very few of those, how important are those? We know that the vast majority of those just clear on their own. By the time you call them back after 2 days, yeah, the kid's fine. What are you calling me for? Yeah. Kind of thing like that. So, when you start talking about 1 in 400, that's what we're talking about. 1 in 400 of these things will be positive.
The whole story of bacteremia being a serious illness is about Haemophilus. Haemophilus influenza type B, if it's doing the backstroke in your bloodstream, it's going to find something to eat. Your cheek, your femur, but it doesn't care. That's a nasty bug. Strep doing the backstroke in your bloodstream is nothing. Your immune system's like, let it do a few laps, I'll get it later. But, Haemophilus is a real disease, but Haemophilus type B is gone.
40 is one of the most disturbing papers of the year. So we need to go through some of the details of this. So this is an Israeli study. So it's an Israeli study, and what they did is they took healthy actors. These people are completely healthy. They visited 32 clinicians. They made the point of saying that 30 of them were trained outside of the United States.
If they said they'd ask for morphine, I know those people.
Yeah, I don't know what they meant by that, meaning they were Israeli doctors or they trained someplace else and were now in Israel. I don't know what that meant.
It meant that, most of the doctors in Israel are actually European trained. So right. I think what they're trying to say is that maybe it doesn't apply to us. We would never do this. Right. Absolutely not.
So what they did is they gave these actors two different scenarios. A viral scenario, 2-day history of sore throat, hoarseness, headache, fever, that kind of stuff, or a bacterial infection scenario. Sore throat with headache, fever, malodor of the mouth, but without cough or nasal discharge. So they gave him one of those two, and then none of the actors had any physical findings whatsoever.
Because they were well.
And then they went back and looked at what happened in the charts with these folks. So the physicians recorded slight, moderate, or severe pharyngeal erythema for 41 and 34%. They had, and 22 and 31% of those presenting with the bacterial script. And exudate was recorded for 6% and 25% of the actors with viral and bacterial scripts. And lymphadenopathy, 16 and 26%. They did throat cultures on them and then prescribed antibiotics 21 and 79% of the time.
And I wouldn't call back on the throat cultures, imagine that.
Right. So, unbelievable. Unbelievable. I mean, you can all draw your own conclusions from this, but this is really a gutsy study to do that, is to send around secret shoppers and see what people are doing there. Amazing.
It's amazing because, you know, we've always said one ear is always redder than the other, right? You know, these papers on otitis media where they're going to bring in that thing that you put in there that actually shows you how the tympanic membrane responds. And one of the gripes about those things that bring actual science to the diagnosis of otitis media is a lot of clinicians want nothing to do with them. I do not want anything to get in the way of me calling that ear redder than the other one if I want to, if it suits my needs. And if I decide to call it redder than the other one, then I'm going to create a chart that justifies my antibiotics so that some of these wise guy ED management people don't call me on the carpet for prescribing unnecessary antibiotics. So my bronchitis patient that I want to give antibiotics to has an early infiltrate on their x-ray. Or, you know, and if it's a sore throat, then they're going to have a center score of 3 or a McIsaac score of 4. I'm going to build a chart. Now, since I can't change their age in the McIsaac score, I'm going to have to invent some scant mucopurulent discharge on the exudate or something. I'm going to have to build a chart that's consistent with it. So these clinicians decided they were going to treat with antibiotics and built charts to support them regardless of what they saw in front of them.
Obviously. I'm sure Dr. Ketamine has now, been assigned to patrol on the West Bank. It's unfortunate he's, had an incident since then. It was friendly fire, they call it. Could happen.
41 is about, how do you pronounce this syndrome here? Are you guys French? Lemierre?
Lemierre.
Yeah.
You haven't had a couple of these?
No,
a couple of these.
Actually, I think we saw one. We just didn't diagnose it.
Yeah, good.
You sent it to us for lower level of care.
Yeah, right.
So here's an 18-year-old previously well kid who's got a sore throat and negative strep screen. That's really important. Who's quite symptomatic. He gets worse. Sepsis, left internal jugular vein thrombosis, respiratory distress, septic emboli going to the lungs. And they talk about this fusobacterium that causes this infection in the throat that is characterized by metastatic abscesses secondary to septic thrombophlebitis. And the key is sore throat with unilateral neck pain. And we saw one of these actually when we were doing a course in Las Vegas. It was our AV guy. And they thought when they went to the hospital that it was a peritonsillar abscess, but they said we don't need to drain it. I think the diagnosis was very wrong because this guy basically had severe pain in one side of his neck. So, have you ever seen this diagnosis?
Oh, yeah.
Yeah. I think an experienced clinician in their lifetime will see 1 or 2. I've seen 2 so far.
So, that's your quota? You're done?
And then, yeah, that's it. And then, but I looked it up at the time, because we did a review, which always happens. You can't believe how many case reports there are of this in the literature because American Journal of Emergency Medicine did one. It seems like every so often, when somebody sees one, they say, hey, this is a great case report, and it gets published. So there's many, many single case reports of this.
Well, they say the incidence...
Hopkins wrong about this. You should know about this, actually, because it is a really bad disease, and it's kind of cool in a way. You often get metastatic abscesses, back pain. Somebody comes back after that sore throat with back pain and this terrible neck pain. That's what it is.
They say the incidence is increasing, so this paper says... So next month in the abstracts, there's a great study where they have a whole bunch of people who have sore throats, about 900 of them who have sore throats, mostly university students in the United States. And they cultured them for strep, and they also cultured them for non-strep, and and they looked at their physical findings. And about 16% of them had strep, about 19% of them had non-group A beta hemolytic strep, and about 6% had viruses that could be the rest of the viruses. The fact of the matter is that the people who had non-strep, non-group A beta hemolytic strep, were just as likely to have exudates, fever, adenopathy, and those kinds of things. And this paper makes the point that since when is there only one infection in the throat that is worthy of antibiotics? They basically say these people who had group C and D and E non-beta hemolytic strep were sick. Maybe they don't know whether antibiotics would have made them better or not, but they said there's no model in medicine that we have where we would only treat one kind of infection with antibiotics and all the rest would not be. And yet that is the model of a sore throat.
Because you're culturing stuff out of a throat? That means nothing. I mean, most of them are, probably not true infections, they're colonization, and there's, unbelievable data from the 30s, 40s, and 50s. This is when these things were
studied.
Right,
so Fusobacterium, one of the thoughts is this is one of these new colonizing things. In fact, Dave Talon, it's not just our mouths either. In dog bites, he grew out this same Fusobacterium thing.
Yeah, it's an anaerobe. It's there. I mean, but I think that's a little different than what Rick's talking about. I mean, let's say what the standard of care is, really. I mean, Group A, beta hemolytic strep, is really the only one of those that should get treated. None of them have any of the non-suppurative complications, and the studies from, earlier than that really indicate that these are not causing symptoms. People who you culture that out of are not more likely to have symptoms than people who you don't culture it out of. So if you do 100 people in this room, there'll probably be 15 people with it. If you do 100 people with a sore throat, there'll be 15 people with it. That means you're not supposed to treat it.
The other thing that study showed is that if you had a negative strep screen in your throat, according to these people who did cultures on them, a quarter of those negatives were positive when they did the culture.
Right, but the culture is the wrong test because it gets to 30% colonization. It can't tell the difference between colonization.
Well, that's the point I was going to make is those of you who are treating based on strep screens, you've got to realize that there's going to be false negatives.
And false positives.
And the false positives will be carriers, but you won't know who they are because these people are coming into you because they have a sore throat and they're going to get treated one way or the other. But one of the things that happened recently in the United States is, and our hospital got nailed on this, the Joint Commission came around, the Inspector General kind of thing there, and basically said, if you do a strep screen and it is negative and you automatically don't do a culture, they cited us for that. They said, because if you read the package insert, all of the package inserts recommend that a culture be done in the setting of a negative strep screen. So now we took a $10 disease and then we've made it a $300 disease because of this reflex testing that is done. So I basically told our doctors, don't bother with these strep screens. They're really not as helpful as you may think, and you're really going to create a problem.
They're not helpful, and the CDC has decided that you should either use the center criteria or the McIsaac's criteria and make a clinical diagnosis.
That's the point. The Joint Commission cited the American Academy of Pediatrics and the Infectious Disease Society of America as supporting their point of view. On the other hand, the American Academy of Family Physicians, the CDC, and the World Health Organization all say, take the other point of view, that you can do clinical stratification using the center criteria, and you'll be right most of the time.
And remember, the treatment makes the disease better by maybe 12 hours. Maybe. And that the treatment is, how much does it cost? Well, at Walmart, it basically doesn't cost anything. $4 maybe. And how much does the culture and the rapid strep cost? I don't know, but you can be sure it's 20 times that. It is just nutty to actually do these things,
And the other question is for pharyngitis, what are the suppurative complications? So I personally don't believe that a peritonsillar abscess is a suppurative complication of pharyngitis. I think it's a separate disease. You don't hear people come and say I had a sore throat for a week and now I got this. They come in and go,
That's unusual.
Yeah, it is.
They don't have. Lemierre's is really the only suppurative complication, and it's very rare. As opposed to sinusitis.
That's not a strep.
But that's not a strep disease.
No,
just
know,
like I think anaerobe. I think you're right.
Of suppurative complication of pharyngitis. I didn't say strep.
Okay, good point. Right, exactly.
So the way to get around this not having to do a strep culture, if you're doing rapid streps, is you have two check boxes. One says do a rapid strep, and then below it you can say do or do not do a culture if it's negative. That way, it's a physician's order.
Oh, that's cool.
And it's not the lab's, it's not a policy or procedure. It's a physician order, because that usually trumps just about everything in this kind of thing. And in fact, you're not allowed to charge Medicare unless there's a physician's order for something. So, you're at conflict if they automatically do something without your order for it.
I like it. Number 42. Number 42 is one of those annoying things because it makes us realize that we haven't defined things. We don't really have gold standards, even for things like pneumonia. So this really shouldn't surprise anybody. It's 100 patients that are diagnosed with pneumonia on the basis of a chest x-ray. But what do you think would happen if you did a more sensitive test like a CT? Well, the reason it's called more sensitive is because you'll have more positives. That's what happened. They had 25% more positives when they did the CT. So now the question, I feel like the guru here, the question is, who really had pneumonia? Was it the guy with the infiltrate on x-ray? Were those right to call it? Or was it the ones that had it on CT, even though that extra 25%, they weren't sick? They didn't have fever, they didn't have white counts, they didn't have anything else. It just had a CT finding, and it makes us realize that for so many things, any disease you could think of, pancreatitis, even common diseases, we're not actually sure what we're defining. And as we get more and more sensitive ways of looking at things, we'll get to be able to call more and more diagnoses. So I don't think this is really, says, much more. Obviously, if you want to admit somebody with pneumonia or to treat somebody for pneumonia, when you really don't, you can't even convince yourself like that big breast is an infiltrate or something, you get the CT. Very, very often. They'll say something is, quote, consistent with pneumonia because everything's consistent with pneumonia. That's about where it is.
43 is another one of these papers looking at pneumonia and the gold standard. But 43, I think, has got to be one of the weakest papers in all of Editor's Choice here. 43 looks at like 100-some people with pneumonia symptoms and said, well, some of them had a negative chest x-ray, and so we looked at what happened when they came back in 48 hours, and lo and behold, half of those were positive. So we think they missed pneumonia on the first visit. Not that they had progression from something that was pneumonia 2 days ago to something that was pneumonia now. Who knows? But their gold standard in this paper, which was hysterical, was one thorax radiologist. He was a specialist. So there was no inter-rater reliability. There was no checking with the emergency physician as to what they thought. There was none of that. And we've done studies. Some of my favorite studies on inter-rater reliability are where they show radiologists 30 chest x-rays, and they give them a story, and they ask them, is there pneumonia there? And what they think is they're looking at 30 different chest x-rays, but they're looking at 10 chest x-rays 3 times. And not only do they not agree with each other as to whether pneumonia is there, but they don't agree with themselves when they're looking at the same chest x-ray. So the idea that one radiologist could be the gold standard for this is crazy. They did that with cardiologists, too. With auscultation, they had these chests draped out on patients with fixed M-mode findings, on their echo, so they got a murmur. It's fixed M-mode findings. So they asked the cardiology gurus to listen to these chests. They thought they were listening to 30. They were listening to 10 3 times. Same thing. Not only did they not agree with each other about what they were hearing on people with fixed M-mode findings, but they didn't agree with themselves when they were listening to the same thing. So whenever someone comes down and says, did you pick up that S3 or that paradoxically split S2? I'm like, yeah, and what about the diastolic rumble? Did you hear that? Yeah. They're more full of shit than a Christmas turkey and their stuff.
Well, with 43 is the same, somewhat same, as a paper we did last year, a Canadian study, where they had huge number of patients admitted to the hospital by an ER doc with a diagnosis of pneumonia where the radiologist said there was no pneumonia on the x-ray. And then within a day or two, they all read pneumonia on the x-ray and follow-up. So these were very brave clinicians who did 2 things. One is they read the clinical scenario as consistent enough and they're sick enough to come in the hospital. So I think one of the scenarios here is that sometimes it just doesn't show radiographically soon enough. And it's not that the ER doc was superior at reading the chest x-ray, they were just superior at reading the patient.
Right. Exam plus x-ray is greater than x-ray no matter how much you know about x-ray.
Well, yeah, there are a couple
something the radiologists never want to acknowledge.
One thing we've known for a long time is pneumonia, especially pneumococcal pneumonia. You are sick for that for quite a while before it shows on the x-ray. So that's part of it.
There's a lag.
But I think, and there's a lag in it going away after the person gets better.
Yeah.
That's known for a long time, too. But I actually think for 43, all you are looking at is inter-rater disagreement.
Right.
I mean, if you look at it, that's all it is, because then they go ahead, they say here within 48 hours, doesn't sound like it was part of the study, but within 48 hours, they either had a bunch of them, 10 of them, had a repeat chest x-ray or a CT, and guess how many of them confirmed that there was pneumonia? Exactly 50%. Just what you would guess. It's exactly what you think, you know. So if I call a pneumonia that you don't call, and we give it to, like, you know, a neutral third party, a CT, half of the time it says what you said. That's what inter-observer disagreement's about. This is, and in many studies, there's a 20, 30, or 40% disagreement, even more than this.
All right, 44. 44 is a great little study. It's what I call a meat and potatoes emergency department issue. If you have kids with asthma and you're going to put them on steroids, do you have to put them on 5 days, or is 3 days just as good? The Australians do a lot of great practical studies, sort of well done, good ER issues. So they took these kids, they randomized them to a 5-day course of something, either 3 days of prednisolone and 2 days of placebo, or 5 days of prednisolone. They followed them for a while after that, no difference in anything. So you're going to put them on steroids, you can put them on steroids for 3 days. I like that.
I like it too because we've done these other papers that talk about what happens to little kids when you send them home on steroids. Well, you know what happens. They climb the walls. They got that little steroid psychosis. So the question is, if there's no difference in outcome in the asthma, then a shorter course, you know, for the people who have to actually take care of these kids at home climbing the walls, I'm for it.
And you'll decrease the risk of atrial fibrillation.
All right. What's your question? Oh, one day, you can give a single dose dexamethasone, which has a half-life of 36 hours. Every reason to suspect that would work the same. But let me just give a little slightly different thing on this. I mean, you know, the difference, the ones that had to get additional steroids was 8% in one group, 5% in the other. Since there's only 100 in each group, that's 8 kids versus 5 kids. But let's say there were 1,000 in each group and it was 80 versus 50. Isn't that exactly what you would expect pretty much in a 2-day difference? We all know that most kids with asthma will have, you know, they have an exacerbation that gets better in a few days. And if you get them over that with 3 days of steroids, that'd be fine. And you would guess that there would be some percentage of them, maybe 10 or 12%, that wouldn't be fine. And that's why you're giving the extra 2 days. It's that 10 or 20%. Now, maybe you're wrong to do it. And that's just what this actually showed. It showed that, of course, it doesn't do very much in the vast majority, but there's a couple of kids in which it would actually might make a little bit of a difference. Now, is that worth making them all crazy? I think you could easily say no. Other people might say, yeah, you know, if we can make 10% of them better, we should do that. It's not really a medical question, but I don't think this said that it did nothing. It just said it didn't do a whole lot, you know, much more better. And every steroid thing is like that, right? It's like how many angels dance on the head of a pin. What if you use 60 milligrams? Here they used a maximum of 50. What if you'd use 30? You think you could tell any damn difference? Of course not.
And the whole dogma with asthma, right, there's the common statement of asthma is it gets better in 3 hours or 3 days, right? That's the standard teaching asthma because it's either primarily bronchoconstrictive or primary inflammatory. If it's bronchoconstrictive, you'll break them and they'll get better in the emergency room. If it's inflammatory, they're going to be sick for a couple of days. And that's why all the OBS unit papers on asthma say that asthma is a bad disease for the OBS unit. Because if they don't get better in the emergency room, they're not going to be better at the end of 24 hours either.
I like it.
45 is a kind of interesting paper. It talks about giving people who have asthma attacks nebulized steroids or IV steroids or both. 73 adults, Israeli study. At 2 hours, they looked at their dyspnea scores and their peak flows, and the people who had gotten both did better in terms of both of those measures. The admission rate for IV steroid patients was 48% versus 20% for the people who got inhaled steroids. So the idea here is maybe you can attack them by giving them some topical stuff which goes into the lung and causes some shrinkage of their mucosa and giving them systemic things as well. Anybody, any of you using inhaled steroids in the treatment of asthma now? So only a few hands, because there are other studies that talk about, you know, it doesn't need to be this steroid. It could be things like this Decadron and other inhaled steroids that are strong, which have some topical effect in terms of vasoconstriction, which works quite quickly, kicks in with the other anti-inflammatory effect.
I don't actually care if you use inhaled steroids, but let's just look at the paper for a second that's disconcerting. I mean, what are the total number of patients in here? 73, right? Adults. There's there's actually 25 in each group. There's 3 groups that they did here. So that's 25. So when they give the percentages, if you add it out here, in that the first 2 groups, the difference they're making is the difference between 5 patients and 11 patients in terms of admission. You know, this big difference in admission. So whenever you're doing a study that's based on 6 patients, and remember, this is not blinded, right? They didn't give placebo inhalation here, so the doctors all knew who got it. I mean,
Plus
maybe it does something a little quicker. Maybe it does. That's all fine. But, to do it on 5 patients in Israel that's not blinded, to start to give people with reactive airway disease inhaled stuff, I don't know.
The decision to admit is not just a single parameter about
totally
how good their
subjective.
lungs are. It's,
And you
my
don't-
doctor wants to admit me. That's why I'm here.
And you don't think some of those guys in the emergency department doing this were doing the study, and they didn't have a prejudice for this? That's why they're doing the study. They say, this guy got inhaled. Yeah, he can go home. I mean, who you send home is totally, it's totally, not totally arbitrary, but it's a very subjective endpoint. So I would, I don't know, a little grain of salt on that one maybe. In general, steroids take a while to work. 46, I'll spend 1 minute on. They're actually talking about a single case, which shows you how bad it is. But it's not that it's so rare because it's not a disease, it's an intervention. The idea is when you have these bad asthmatics and you're trying to not intubate them, and you've given them maybe you've given them some Heliox, maybe a little lidocaine, maybe some definitely magnesium, maybe some theophylline, who knows, you've done all that kind of stuff.
Mask off, they're struggling.
They're doing, and you don't want to intubate them, and somebody says, why don't we give ketamine a try? Well, there's 2 controlled studies, 2 sort of things you might think of as studies, both lousy in the literature, at least one, I think both were in our database. That one, which used a tiny dose, of ketamine, couldn't show, a significant difference, although it certainly didn't show that there was no difference. And then there's a bunch of case reports, and that's what this guy says. There's 10 case reports that sound kind of good, really. So there's 11 case reports, and he's got a lady where it worked kind of well. I've done it a couple of times with 1 milligram or between 0.5 and 1 milligram per kilogram. I liked it. Who knows?
So this is about a topic. So many people have made the mistake of giving a panicking asthmatic a little bit of a benzo in an attempt to get their panic down so that you could treat them and make them more compliant. Sometimes it works. Sometimes it results in disaster and they lose their respiratory drive. And so that's sort of been poo-pooed. But there are clearly a subset of asthma patients who are in this hyperacute crashing asthma place, and they're too panicked and too stressed to cooperate. They won't listen to you. They won't take their therapy. No amount of coaching will do it. And they have, and I'm not the only person to refer to them this way, they have a component of psychoasthma. There are actually people who degranulate under stressful situations. We know some people degranulate and get exercise-induced asthma. We know some people degranulate and they get cold-induced asthma. There are other people who get emotional distress asthma. So as they start getting a bad attack, they get more distressed, which makes their attack worse. And that keeps going until they come to you panicked, thrashing, and you can't get anything done. And so one of the reasons why you might not have to intubate them is you give them a full dissociative dose of ketamine, which means they have now no psyche. So ketamine, which ablates your psyche, will cure psychoasthma. And so you might be able to then hold off intubating them. And so that's been suggested. Now, the problem with it is that ketamine, if you do that and you then need to intubate them, ketamine's not a great induction agent because all their airway reflexes and things are intact and they protect their airway, and it's not a great way to intubate someone, so you're still going to have to go ahead and do the rest of your work and rapid sequence them. But this is one of these case reports that's out there that says we aborted a hyperacute event of asthma by ketamining them, and then we didn't have to intubate them, even though we were getting ready to.
I think this is. I think they just made a mistake and turned it into a positive. I think
No, it's
they
been
gave them the wrong dose and
No,
said,
it's
"Oh,
been
we
reported
didn't
out
give
there.
enough."
It's
No,
been
I know it's
reported
been
out
reported. I've given people a full dose to intubate them, and by the time I got around to doing it, they were better.
Yeah.
So you just didn't, because actually you don't have to intubate them then at that point.
Right, because their respiratory drive is good,
they
their
still have
airway
respiratory
protection's
drive,
intact, and so ketamine might get you off that. And it's kind of interesting stuff, but the subdissociative doses won't work because then they still have psyche.
I don't
so
know.
They still have psychiatric.
That what you're saying may be true, but we actually don't know
I know.
that.
We don't know.
Right.
We don't know.
I
I
do
agree.
not think, like, for example, there's a very large anesthesia literature on intubating people with asthma. That's a little different than what we're talking about.
Right.
We're talking about intubating people for asthma. But think if you're an anesthesiologist and a decent percent of the population has the disease, so they for a long time have used ketamine for that. And They believe it is not just because it's the psyche thing, that it actually relaxes.
Yeah, there's no question.
You know,
Yeah,
that
so
it actually
it's
is
a bronchodilator.
It's actually a bronchodilator.
Ketamine is.
So that's the idea. So maybe in some people you could give a low dose, 0.75, 1 milligram per kilogram, and, you know, you would chill them out a little bit, and you would bronchodilate them, and what Billy didn't say, but he meant, you know, he was inherent in this, unlike doing the same thing with a benzo or a phenothiazine, is you are not knocking out the respiratory drive at all. In fact, you might be increasing it. So it makes perfect sense, but it'd be nice to have a big study with it.
The other thing that ketamine does is it increases endogenous catechols, so it's like giving them a little boost of epi, which is also not a bad thing to do in someone who's crashing from asthma. And the last thing I'll say about this is it used to be said about asthmatics who were the crashing asthmatic who comes in, and these aren't well studied for all the reasons I alluded to earlier in COPD. They're deleted from the literature. But there have been a couple recent reports on the crashing asthmatic, and what they say, what we used to think was the crashing asthmatic was the asthmatic who stayed home abusing their inhaler, getting sicker and sicker, and abusing their inhaler more and more, who then comes in at the very end, and it's too late, and they crash, and we end up having to intubate them, or they die, or whatever. What the literature has shown is that that's absolutely just the opposite of what happens in the worst asthmatics, that the worst asthmatics are quote-unquote hyperacute asthmatics that have been sick for less than 4 hours. That's who are the worst asthmatics. They come in panicking, hypoxic. Some of them have higher air components. Rick always cringes when I tell the story. I was working at his hospital. They brought this lady in, moving no air, thrashing like a white rhino on Mutual of Omaha's Wild Kingdom. I couldn't bag her. I couldn't do anything. Finally, I put a knee on her arm, and I paralyzed her and intubated her. And so we got some bronchodilators in her, and she was, you know, and I sedated her and all that. And when the sedation was lightening up, she grabbed a hand and went like this, like she wanted to write something. I was like, oh, good, history, that will help. So I got her a piece of paper, and what she wrote, exactly as she wrote it, with the same emphasis, because she used capital letters for the first 2 words. She writes on the piece of paper, fucking bitch at Nordstrom sprayed me with cologne. So the story in the end was she walked into Nordstrom's, one of those ladies with the white coat and the perfect makeup, came, oh, try this, and she went, and she staggered out of the store and made it to a phone bank where she called 911. And so she had both a hyperacute asthma with some of this upper airway laryngospasm component and almost died. I ended up lightening her up some more and extubating her.
Do you know what perfume that was? Because I once had a girl that had a similar effect on me.
So these hyperacute ones are surprisingly turn out to be the ones that are dying of asthma.
Right, and this idea of abusing inhaler,
Yeah.
I mean, I could picture a way in which you could do that, but not by using it, not by inhaling it. I mean, what do we do when the guy abuses the inhaler? He comes into the ED, he's used it 20 times, we say, I'll give you albuterol. Yeah, that's good. That makes a lot of sense.
47 is an interesting paper on bronchiolitis. And they said they wanted to look at whether epinephrine and dexamethasone work in bronchiolitis. Well, that's kind of a weird proposition up front because we've defined bronchiolitis as those that don't get better with epinephrine and dexamethasone. So in a way, they're sort of looking to do it. So this was a big Canadian trial. It's the PERC group. It's a well kind of designed thing. 800 kids. They made 4 groups out of that, so it's 200 in each group. The bummer of the study was, and they published it anyway, and I don't blame them. I would have published it if I'd done that much work. The bummer is that though they randomized the groups, it turned out that the least sick children, by chance, ended up in the combination therapy group. So they had a sort of a critical flaw that the randomization, which is supposed to take care of that, didn't fix. So in other words, they would have needed to do another 800 kids to fix that, to make the numbers work out right. And so they said that although the data says that the combination of epinephrine and dexamethasone worked, when they adjusted it for severity of illness, it didn't work. And so this is one of those sort of unfortunate things, and it happens sometimes. You do a big study, you're doing your best to randomize it, to design it right. The design was not flawed. It just so happened that the randomization put too many well kids in the combo therapy
And it's
group.
very hard, maybe impossible, to correct for that retrospectively. You always try to do it. Very hard. This is what Jerry Hoffman thinks happened in the NINS trial. And when it happens, I think it is a fatal flaw. Because then it's almost like a retrospective study when you're doing that. And so I'd be pretty surprised, as you'll see, if even the authors would be pretty surprised if this combination worked, but they got a lead article. In the journal.
Fortunately, you know, if you did this wrong and it came up with a conclusion opposite to what the bulk of the literature said, then you got a real problem, Ollie. Fortunately, their conclusion was that the combo therapy wasn't any better than nothing, so it was the same as the general drift of the literature. So at least their fatally flawed study didn't try to say the opposite to what the bulk of the literature on the topic says.
All right, 48. You have a little kid who's got what you think is a virus infection. They're doing a little wheezing, but they're not an asthmatic. Will steroids help them or not? Answer, no. They don't get any better when you put them on steroids. They're probably not asthmatic.
Well, 49 is one of these studies on bronchiolitis as well that talks about, because there have been so many studies on this that says this stuff must work. Otherwise there's absolutely nothing to do for these kids. And sometimes they was positive and sometimes they're negative, but most of them were negative. So here's a study on bronchiolitis, a small study. It wasn't 800 kids, it was only 69 kids, because that's all you needed to prove how great this stuff worked. This is a 5 months old, randomized and nebulized albuterol.
Turkish study.
Every 6 hours. What are you implying by that, Doctor?
No, just thought I'd kind of let the audience in on.
I've already warned them about these Turkish studies.
That's right.
Ipratropium, which is a drug that is rarely used in the treatment of this disorder, and placebo. And they thought that active treatment resulted in a significantly greater improvement at 30 minutes, 8 hours, and 24 hours. And also better oxygenation at 8 and 24 hours. But the numbers are small, and whether they, in fact, are clinically significant is probably they're not. Mean duration of hospitalization was unchanged. So this said, maybe, because every one of these kids who have bronchiolitis, despite what the literature says, everybody uses some drugs that are typically used in asthma. What are you going to do, stand there and do nothing? So that doesn't matter what the literature says. They still are getting some kind of adrenergics. They're still getting some oxygen. And they may throw in a little steroids into as well, because we have no other choices.
Right, and even in this case, I would really be skeptical of this. After 24 hours, there was no difference in anything. So I guess what happened is, the rest of the group of investigators in number 50 said, listen, we can't find a drug that works. Steroids don't work. Epi doesn't have the whole thing. Why don't we try an intervention? How about some, nasal BiPAP kind of thing? And so instead of doing 800 patients, like studies, or CPAP, it's called nasal CPAP is what they do. And it's a special device they made. I don't know if the guy who's publishing it has to do with it, but it sounds like it, called the Infant Flow Ventilator Electromedical. I think they sell marital aids too. And they tried this thing not in 800 patients like the two previous studies, 69 patients like the last study, but in just a few less, 12 patients. And so they put the CPAP on, and what was their control group? There actually wasn't one. And so they watched the 12 patients, and they kind of liked it. They said, yeah, we kind of liked it. They seemed to get better. I don't know. That's as good as I don't know. So I don't actually have the study. It doesn't sound like an
one
Eli
of those
thing.
first trials of a device for it, and we'll have to see another half a dozen to see if this matters or not. It is possible that positive airway pressure will become recognized as beneficial in bronchiolitis down the road. This paper certainly doesn't prove it. Comment. Well, if you'd written them up, it'd been a bigger storyline than this paper.
Twice as good.
51 is a paper on BNP in all patients with dyspnea. Now, earlier we were talking about sick COPDers and how CHF can be mixed in there, and that would be a selected use of BNP in a selected population where there's a high risk of CHF and you may not recognize it. That's different from what this paper did. This paper said, let's do it in everyone who looks really short of breath when they come in. And so some of them were COPD, some of them were asthma, some were pneumonia, some were pulmonary fibrosis. And what they found was if you use this test in an indiscriminate fashion, and I think that this result is probably correct, if you did it in an indiscriminate fashion and they looked at weird outcomes, I'll grant you that, but they said there was no change in hospital admission rates, no change in hospital length of stay, no change in who lived or died, no change in bounce back or readmission, and no change in their medical regimens, which sort of doesn't make sense, because if you found failure, don't you change the medical regimen to manage the failure?
Or if you found non-failure and somebody you thought was in failure.
Right.
Yeah, I don't know what to make of this study exactly. I think I'll admit, because I believe that BNP is actually useful when used properly. And
Selectively.
Selectively.
Right.
And almost every clinician that you talk to, actually agrees with that. Jerry Hoffman doesn't, but almost every clinician actually does. And so I'm not sure what to make of this. I think a couple of things. Number one, did you see how they decided this? It's kind of funny. The raters, the people who looked at the final outcomes, what seemed like pretty objective outcomes, were aware of the patient group allocation. Why on earth would you do that if you did a study like this?
Yeah, you shouldn't do
You shouldn't do that. So maybe the guy who's rating it, he's a guy that doesn't believe in BNP. So whenever he sees that somebody who's in the BNP group, he's, maybe, I don't understand, I'm not quite sure how he could do it, but why would you actually do that thing? The second thing is, the fact that it came out in the wash, this may not mean that you didn't change people's allocations. There may have been people who you otherwise would have diagnosed with CHF that you now said, Jesus, the BNP is 47, I think he has COPD, and the vice versa, but there might have been that many in each group. In other words, you could have greatly improved diagnoses, maybe by 10% in each group, and it just so happens that the admission times, the time you're in the hospital for COPD and for CHF is about the same. So you haven't proved that you haven't done anything, but I will still admit it is the strongest negative BNP paper I've seen, but I do think it has a lot to do with the fact you've done it indiscriminately.
Well, indiscriminately without being blinded to whether they got it or not. And the people at the Alfred should know better than that. I mean, they got that whole research group. They're supposed to know how to do that.
If getting one of these tests is really not any good, let's just get everything in somebody who's short of breath. That's what 52 is here. So they have what they call a triage profiler, short of breath, point-of-care biomarker panel.
Nightmare.
So these are people who have acute shortness of breath, and they come in and they get this biomarker panel made by Biosite, and it measures troponin I, myoglobin, CKMB, D-dimer, and BNP, and it's got results available in 15 minutes. I think I actually rejected this paper for pre-review, and I'm not sure how it got published, unless maybe they changed it. But so they had a physician reviewer come up with the final diagnosis of what they thought. They were blinded to the Biosite, but it doesn't say they were blinded to other testing. Like if you saw somebody who was short of breath and you thought they might have an MI and you got a troponin I, that'll show up in the record, and depending on how they want to use that. And what they found was that getting this profiler was no better than physician judgment when they were blinded to the profiler. I mean, it's a really strange study. I don't know if they believed that each and every test was its own gold standard, which I think is what they assumed here, that if your BNP was elevated over 100, you were defined as having congestive heart failure and not a big PE or something else. I mean, this is the craziest study I've ever heard. But at least it came to the correct conclusion. It's not useful to do that.
All right, moving to something a little simpler. 53, routine packing of cutaneous abscesses, 48 abscesses, not more than 5 centimeters on the extremities, randomized to packing with a quarter-inch gauze or no packing. All of them got antibiotics, which is a shame because, you can say, well, that's made the difference. So they should have done no antibiotics or half antibiotics to really answer the question. 60% of them were positive for MRSA, and at 48-hour follow-up of 2/3 of the cases, a blinded physician was not able to distinguish who had one treatment from the other, packing or no packing. None of the 36 contacted at 10 to 15 days reported complications. Packing is less painful after they used less ibuprofen and
packing's less painful.
Non-packing.
I hope non-packing's less painful than packing because I think packing hurts.
Probably in the 70s we did a paper. The British are really nuts. They did a study where they curated out abscesses. They lanced them and then curated away, and then they sutured them closed. They didn't even give them a chance. It was loosely sutured, but it was sutured closed. And they found that they worked out just fine. So a lot of us have this ritual treatment. The idea is, keep it open a little bit, maybe put a little wick in there. But this idea of filling the hole full of rags is another matter.
Yeah, and think about the idea that it's a rope ladder, a cargo netting, which the bacteria are climbing their way out. I mean, that's sort of the mythic idea.
I guess the idea is that it doesn't close over on the top. It sort of seems like it might make some sense. But, when you look at these things, including soaking, I mean, how many people? Somebody comes in with a boil, not quite ready to pat. You say you go home and soak that with whatever your mother used. Like some mothers used Epsom salts. What'd your mother use?
Clorox.
What about black?
That would figure, all right.
Boiling.
Now
Never give it the chance to soak me. She used Clorox.
I believe that's why they were called white trash. Maybe. I don't know if that had to do with it. None of that's proved. Does soaking do absolutely anything? Probably not.
You
That'd
need
be
to
a nice
use
thing
drawing
do.
salve.
Yeah,
Either
that-
drawing
No,
salve or
what-
boilies. I mean, everybody.
It
knows
depends.
that.
That's actually it depends on ethnicity. Different groups, use different things, and they all think it's great. And in Asian cultures, they have their own type of drawing things too. And my guess is it all works the same. All right.
Yeah, you had a comment?
Well, that's not very. You can't bill for that, can you?
No, they probably need to be. They're painful. There's a lot of tension underneath them. They came to you for treatment. Yeah, they're eventually going to rupture.
Into a hollow viscous. Or,
Yeah. No, you
No,
should drain them. Obviously,
I would.
if there's a fluxuant
They're
area, it should be
drainable.
drained.
They should
Yeah.
drain.
But
Drainage
sometimes
is what it's all about.
How many times have you done this? You say, "Well, we're going to lance this boil," and you lance it, and there's nothing comes out. And damn. Now they're basically saying use an ultrasound to determine.
now you
if
made a
there's
pathway in case it develops.
No. You have to prepare for that. Okay, so every single time I talk to the person about, sometimes there's a little less suppuration than we expect, and then we'll just get some blood. But that's good because the bleeding will take out the evil humors, and that way it's good that you came in early. And I tell you, people believe this stuff. It's unbelievable.
Yeah, in the back, you had a
yeah,
comment.
question. Like a square. Some people make a cross, so it's not supposed to be able to a cross. Yeah.
Yeah.
So it's
You're showing yourself that's
I-
not a cross.
I
A cross
tried-
with the little arms on it, that's something different, Mike.
Oh. Well, I've been trying a 6-pointed star, and I don't know. It seems to work for me.
No,
I don't know if a study looked at it.
One of the things that has been coming up, though, that not necessarily the size of the incision, but in several studies, the completeness of the drainage is relevant. And so one of the problems with MRSA is they're not as the old days. Remember the old days? You'd lance an abscess, and it was like Mount Vesuvius. Ooh, it all just came out and ran, and it was nice. Now you lance it, a little bit of dishwater comes out. There's all these knots in there, and they take a little more work. And so one of my statements to the residents is that when you see these MRSA things, it's I and D and D. It's incision, drainage, and a little bit of debridement, breaking up the loculations. There's that little core in there when it's a pharyngitis. That's got to go. But no one has, so we know that completeness of the incision and drainage matters. That we know. If you don't do it completely, they recur. But no one has ever said, well, what size laceration or what type of laceration results in complete drainage. I think each abscess is a little bit different, particularly for the ones that have a furuncular start, like at the base of the head where your stethoscope was rubbing. I've drained a bunch there on docs and nurses. It's a good argument for getting that waste carrier for your stethoscope. But, those kinds of things where there's a hair base to them, they don't drain easily. There's like little knots and stuff in there you got to break up.
A lot of this is the art of medicine still, I'm afraid. Yeah. All right, 54. 54 is one of those IV opiate studies that say we're not doing it very well. Why do you think they're maybe not doing it too well in this? Let me just guess that these 691 patients in Rochester that got a median dose for painful things equivalent to 4 milligrams of morphine. I'm just going to guess that if you gave them that, more than 50% would say, I don't feel all that much better. And you want to know why? Because there's an article or 2 and 3 or 10 in the annals that say even if you give 0.1 milligrams per kilogram, like 7 milligrams, twice what these kind of people have, 7 or 8 milligrams to an adult, still 50% don't get 50% release. So that's what happened here. They didn't give enough, and 1/3 continued to have a pain score of 70 or higher. 60% did not achieve 50%. The whole thing, all the stuff you might expect. And I'll just do the editorial thing here. I'll tell you what I tell my residents, and they haven't learned it. They don't, because they seem to learn it from the resident ahead of them. They give 2 milligram doses, 4 milligram doses, 6 milligram doses. The best sentence you're going to hear from this conference is going to come now. When you treat a painful problem in the emergency department with a narcotic analgesic, the first dose should be too high, not too low. Don't give 6 milligrams of morphine when you can give 12, for example. Nothing bad ever happens by giving too much. Everything bad happens by giving too little. You think of what happens when you start doing this 4, 6, 8 milligram crap. What happens is, half the time, or 60% in this case, they say, that's not enough, I need more pain medicine. Then you're thinking, I thought that guy was a bad pain seeker. But you don't know that because you weren't a good doctor. You didn't give him enough medicine to start with. Think of what happens if you give him 12 milligrams and then he says it. Then he very likely is a pain seeker or you got the diagnosis wrong. I mean, at least you can make a judgment. You can decide, this is a guy I do need the CT on. He's still having pain. I thought it was just a regular kidney stone, but I have to do that. I have to evaluate it. But you can't do that when you've given too little to start with. So just start off giving too much.
Well, I don't, it may have been the best thing that they ever heard, but I think if you want to start,
it's certainly the best I've heard.
If you want to start lower, which is fine, the problem is it's work labor intensive. Now you have to reassess and give more.
And get the nurse to give more?
Right, that's what I'm saying. The whole point of this paper is that docs who gave opiates, even though they finally got them off their can to give the opiates and got them aware of oligoanalgesia enough to prescribe opiates, but they didn't reassess or prescribe enough. And so, I'm not in favor of having respiratory arrests all over the department. If you're going to start low, you got to repeat it though. But I do think 4 is a homeopathic dose to start with. I think 8's
start with
reasonable.
a tenth per kilogram if you want. We know that 50% of the time that won't work, but start a tenth per kilogram is 7 or 8. And in any case, whatever you give, there's such huge variability, you just have to reassess it. If you're in a place like mine, and I bet like yours, where reassessing is a big deal, for nurses and all that, then I'd rather do a little bit
It's the reason why Dilaudid, Demerol, which was bashed as a bad pain med. How many of you are in Demerol-free ED? Probably a bunch of you. The real problem with Demerol is if you ask for the right dose, someone will look at you like a criminal. The right dose of Demerol IV is 2 to 3 per kilo, which is a starting dose of 150 to 200 for most humans that are adults. If you ask for 200 of Demerol, the nurse will look at you like, what, you train turkey? And they go, what are you thinking of that? We're not doing that. But if you ask for 2 of Dilaudid, they'll be like, it's only 2 milligrams, sure. It's just they're equivalent doses. 2 of Dilaudid, so the real reason that Dilaudid is a better pain medicine is not that it's better than Demerol, it's that you can actually order the appropriate dose and have someone give it.
Yeah, I wrote a blog on this. I don't know if you told about em-blog. If you go to em-blog.com, I think most of us here actually write blogs for that, and I did a couple on, the whole pain management thing, saying a lot what Billy said. I mean, the reason we got rid of Demerol was just nutty.
It just took too many milligrams.
I don't even think it was that. I think it was that patients liked it too much. They said, that really worked, doctor. Thank you, when you gave them 100 or 125. And so naturally we thought that's not a good thing. And then somebody that did one of those toxicology fellowships, I think, said, that's got a metabolite, even though in the history of emergency medicine that has never caused anyone to have a seizure, and plus morphine has a metabolite too, we'll take away the Demerol. And they said, that sounds good. It's nutty. Okay.
55 is a simple paper that just makes a point that's been made before, that if you have nitrous oxide in your department, you need the right nitrous oxide if you're going to use it for simple procedures. So we have nitrous in our department. We have the wrong nitrous. We have the 50-50 nitrous, the Nitronox that they self-administered. And we use it quite a bit for things, but because it's not strong enough on its own, the concentration of the nitrous is too low, we end up using it as an adjunct rather than as a solo device. So we're going to IND an abscess. We let them pull on the nitrous while we give a little local, and maybe they have a milligram of Dilaudid while we're getting ready to do it. But we can't use the nitrous alone because 50-50 just won't get you there. And that's what this paper found. They looked at 70-30 and 50-50, and they found that 70-30, if you're going to do an IV stick on a kid age 6 to 15, it didn't matter whether you gave it to them for 3 minutes or 5 minutes, and nor should it, because the stuff has instantaneous onset. If you gave 70-30, they had very good responses to that, and you could do an IV without much pain. But when you did the 50-50, it didn't work as well, even if you pushed it for 5 minutes, which also makes, it's not a matter. When you're given the lower concentration, it's not a function of time, it's a function of the concentration of the nitrous. So really, and this has been said by other people who use it, if you're going to use nitrous, you ought to use the 70-30. Unfortunately, in my hospital, we do everything halfway, so we only have the 50-50. I still use it. I still like having it, but I don't use it alone. I have to use it as an adjunct because it's not strong enough.
Right, and it's too dangerous for us to use, so instead we'll let the dentist use it at 70 and 80%. I mean, the guy who discovered
Not
this...
even the dentist, the dental technician.
That's right.
uses it.
I mean, the guy who discovered this 100 years ago knew this. I mean, I don't know.
All right.
Well, you can't say anything.
So-
more.
Well, let's just ask the Australians,
You guys got 70-30, right?
and what do you think?
Yeah.
Did you say splendid?
Splendid and blended.
Blended and splendid.
Yeah. Is it shaken, not stirred? No, it's blended. Okay.
Anybody
Anyone
else?
Using 50-50? Anyone using 50-50 like we are? Another
70.
person. Do you feel the same way I do about it, that that's not really strong enough? How 70-30 in the back? Like it? Mikey likes it.
No, and Mikey loves it.
Mikey loves it.
All right. Next, 56.
Was that?
That's not so easy. Anesthesia's going to have something to say about it.
You got to have a scavenger. Apparently, the
just gotta-
a machine with a scavenger is apparently not that
Oh, it's no
expensive.
big deal at all. It just has a...
No, it's
You
really
have
easy
that.
to get anesthesia to
vacuum.
approve it. You just start calling them down at 3 in the morning to give nitrous, and they'll say, "What the?"
So
and they'll give you the machine.
Australians have the machine to suck up the excess gas.
You got a scavenger.
That's no big deal. We even had it on the Nitronox
Our medical
machine.
students at our medical school scavenged it, no problem.
Oh, the paramedics. It may not be good enough for patients, but for medics, boy, they like this stuff. We used it in Pittsburgh for years and years, never had a labor union problem, nothing like that. It actually, children
All
went
right.
out.
56. This talks about plasma concentrations of oral oxycodone, and they're greatly increased in the elderly. The title says it all. Okay, so the levels are higher, the peak isn't higher, but it lasts longer. So it's just what you'd expect with an older person. You know, they're going to get a little bit higher levels of it. One thing they say is, be careful about how you prescribe it for Tylox, Percodan, and OxyContin. Well, there's 5 milligrams of oxycodone in Tylox, 4.8 in Percodan. No option to change that, whereas that OxyContin has 10, 15, and 20. So you can pick your dose. I think that's about the most you can get out of this
This is
paper.
just another paper that says, remember the mnemonic of when to lower your doses, the clock mnemonic. So children, liver, older, kidney, and what did I miss?
I can never remember
CNS
mnemonics.
disease. CNS disease
All right.
is the other C.
57 says propofol, you can drive home. 98% of these people given
What?
this stuff,
That work for Michael Jackson?
Yeah, you could drive home to Beverly Hills.
98% exhibited full recovery within 30 minutes when they had them stand on one foot, walk in a straight line. The driver simulation test, at 1 hour, 100% of the people passed their driver simulation test. At 2 hours, people who had gotten Dayslim were still goofy. So when you have your colonoscopy, don't bring your wife. You can drive home yourself.
That's well put. 58. This is one of those studies that, it's easy to do. You look at who got CT scans for headaches. So 150 some odd patients, whatever, come in with a headache, and then you see how many of them got scanned, and you see if there were differences in the amount that people scanned based on a bunch of things, including race. And in this one, it turned out, this is Mount Sinai Hospital in New York, that black people who came in with headaches got CT scans a lot less. If you look at those confidence intervals down there, which we talked about a little bit before, you'll see that it was actually a lot less, because the top part of the 95% confidence interval, that would mean the most it would only be half of it. So that, you might interpret that to mean, boy, these guys are pretty bigoted there. They're not doing it. But there's two things about it. Number one, there wasn't a single patient that got the CT scan anyway where it made a difference in anything you had to do.
Decrease the CTs for whites there. The blacks got better care because they got fewer CTs with the same outcome.
That's exactly right. That's number one. And number two, the point of the CT, as they sort of point out here, is that they think 4% of headaches that come in have a subarachnoid hemorrhage. But that in no way means that every patient group is going to be the same in that. Females and old and young and black and white and Hispanic, they may all come in with headaches of different kinds that have very widely differing presentations, and maybe for some ethnic group, it is much less likely. It just, the CT wasn't indicated for that, and you just, you can't tell that from this.
59.
59 is an interesting paper. It refers to a practice that's been out there for years. So at my hospital, whenever we used to, give someone the Haldol blow dart, they either got 5 2-in-1 or 10 2-in-1, which was 10 of Haldol, 2 of Ativan, and 1 of Cogentin. The idea was we'll prevent the akathisia from the Haldol when we give the blow dart. Now, no one ever knew if that worked. I mean, we would garnish that with a mint sprig. It was clearly a recipe. It had never been studied. And it was said that someone ought to study, does simultaneous administration of something like Benadryl or Cogentin, will it decrease the akathisia? So hats off to these people. It's actually a reasonably designed study. So they checked it out. They looked at Benadryl given at the same time as 10 of Reglan, which is metoclopramide, or 20 of Reglan. And 20 of Reglan, that'll make you... You'll be looking at people in the emergency room and saying, ripping your IV out, going, I got to go, man. 20 of Reglan will make you get up and get out of the emergency room. And so they looked at it, and the akathisia rate was 6 to 20%. Clearly it went up, as the dose of Reglan went up, you got more of it. The rate, however, was unaffected by co-administration of the Benadryl. So co-administration of Benadryl at the same time didn't change the overall rate. It changed a little bit the severity. They said there was a little bit less restlessness of those who got it, but they still got it. And they said that most of the patients who got this Reglan-induced akathisia went away by 30 minutes, but there were a few where it persisted to 60 minutes and a few even longer than that. In my experience, this is pretty distressing for the patients. They really, they're hard to manage. You suddenly, some of them at our hospital, we're kind and gentler, so we tie some of these people up, and we're trying to, medicate them to back them off and stuff. I think this is actually a significant problem. I would have loved the Benadryl to have worked, but in this study, it didn't really work. And so my hats off to them for trying it, because I think it's a study that needed to be done. Everyone in here, have you wrestled with a patient with akathisia, ripping their IV out? I got to go. Let's see hands. So it would be really nice to know if giving something at the same time worked. I wish it did. It didn't really. Right. Well, if you give it to... Well, it may not... I don't know. Another comment.
It mentions the restlessness, and I found that the restlessness is more of a problem.
As the positive. So your take on this study would be, even though they said it was negative, your spin would be, if it helped the restlessness, I'll take it anyway.
Yeah.
Yeah, dystonia this is akathisia specifically, but...
This didn't look at that, right.
Yeah, it didn't look at
They
dystonia.
didn't look at that. I think there have been a couple that looked at that.
They've looked at it with compazine, and it seems to have worked with
It
compazine, I
worked
think.
about 50%, as
Yeah.
I remember. We have an article.
So 60 is actually a very interesting paper. I love the fact that they did this. I actually think the cause of death in most chronic alcoholics is probably vitamin toxicity, is what happens.
Banana bag.
They come into your ER once a week, and they get this banana bag. They're toxic after about a year. Anyway, prospective study, they took 75 patients who came in intoxicated, and they measured all these vitamin levels on them, and basically none of them were abnormal. There were a few borderline thiamine levels that were just sort of maybe borderline, but certainly not dangerous kind of stuff. So what they're saying here is the alcohol-intoxicated patient routinely is not vitamin deficient. We don't have to be scared to death that we're going to kill them with the first molecule of glucose if we don't have thiamine on board. The thing I would wish they had done was to say, were they not only acutely intoxicated, but did they seem to have either stigmata or a history of chronic alcoholism, look malnourished, jaundice? I mean, that would be the person that you would really want to focus on, and unfortunately in this they didn't tell us that.
And we see in our hospital, we're like a level 1 alcohol receiving. We're a county hospital that services a dozen sort of missions. So we see exactly the type that Neal's talking about. So we see people with, their cherries and their Dupuytren's and their rhinophyma and all the manifestations you can name of chronic alcoholism. And we, in fact, see a fair amount of Wernicke's and Korsakoffs there. At our hospital, and I'm constantly telling the residents, because they give this person comes in hammered with all these stigmata, they give them the banana bag with 100 of thiamine, and the guy doesn't wake up, and we've already gotten a CT scan and this and that. And the other thing, I go, well, how much thiamine do you give? They go, well, I gave 100. Well, that's only prophylactic for Wernicke's. If they arrive altered with Wernicke's or Korsakoffs, they need gram amounts, somewhere between 500 and a gram of thiamine. I've woken up dozens of people pushing thiamine in our hospital. One guy, I was stopped. I wasn't even attending. I'm walking through the area. They got this NG tube coiled in this guy's left chest who's like 70 with the Dupuytren's, the rhinophyma, all the manifestations. And he's totally out. He's been in the department for 4 hours, not said a word to anyone. He's had every lab under the sun, a CAT scan, the whole thing. So I look at him, I go, did you try pushing some thiamine on him? Because they stopped me to look at the chest. I go, yeah, his stomach's in his chest. And did you look for scars or anything? So I push 500 of thiamine. He sits up and says, "Where the hell am I?" I say, "You're at the hospital." I said, "You know," and he's like, and he's reaching for the NG tube. I said, "You know, we got your stomach's in your chest." He goes, "I know. They stabbed me in the big one." I go, "What do you mean in the big one?" I'm like, "What?" He said, "In WW2, you idiot." He says to me, and he points. Kraut got me right. He points to his bayonet scar in his left flank and says, "I know my stomach's in my chest. I don't want him fixing it. Get off me." And then that, it was like, "Okay, you're fine now. Thanks."
To be fair,
So was that a success?
Yeah, no, it was a success.
That was a success.
That
Okay,
was a
I just
success.
wondered where that story
He
was
completely woke up, was completely oriented, knew what was going on. This is a guy they were going to admit who hadn't spoken a word to anyone, who after 500 of thiamine was like, "Leave me alone. I know my stomach's in my chest. I want to go back to the mission and have another drink."
to be fair, that happens probably at USC, but is extraordinarily rare almost everywhere else, including New York City. I remember, I think it was either Keith Red or Knox Todd had a whole thing on thiamine when they couldn't find a patient where it did anything. Because, nowadays it's not like we learned in medical school. Alcoholics don't come in with small, shrunken livers and with, bad vitamin deficiencies. I mean, that was from the day, and in other countries, including Los Angeles, where most of their calories came from alcohol, and they didn't have anything else. But nowadays, that's actually not what happens.
They've got Wheaties that have thiamine in them.
Right? There are rescue shelters, and there's food, and so even though they may drink just as much, it's really, really rare to find these kind of vitamin
And
deficiencies.
you're absolutely right. You're very right that the
West.
people that we see, they're having 3,000 calories a day. It's just all vodka. We had a guy we called Vodka Bob. I mean that was his name. He had 125 CT scans because every time he'd go pee on a different storefront, the storefront owner would come out with a bat. Stop peeing on my, and your chances of having a subdural when the storefront owner comes out with a Louisville Slugger are fairly high. So he'd had multiple subdurals, and every time he'd come with a head laceration, and you'd know he was ready to go when he called you bitch, regardless of your gender. If he was drunk, he was really, really nice. And as he began to sober up, he'd look, "What are you looking at, bitch?" And you'd be like, "Okay, you can go. You're ready now."